Hello everybody, welcome to the King's Fund and today's webinar focused on implementing new care models. I'm Hugh Aldwick, I'm the Senior Policy Advisor here at the King's Fund and I'm joined by an all-star cast. We've got Don Berwick and Mike Richards, but I'll let you two introduce yourselves if that's okay.
I'm Don Berwick, I'm a pediatrician from the US. I was the founder of the Institute for Healthcare Improvement. I'm now there as a senior fellow and I'm also an international visiting fellow here at the King's Fund.
Quite right.
I'm Mike Richards. In the past life, I was an oncologist. Now I am the Chief Inspector of Hospitals at the Care Quality Commission.
Fantastic, and thank you both for joining us. So, as I say, today's session is focused on implementing new care models, but what on earth does that mean? We've got lots of jargon in the NHS, STPs, MCPs, PACs, ACOs. Essentially what we're going to be talking about are efforts going on up and down the country to improve quality of care, improve the broader health and well-being of local populations, and of course to manage within the available resources for the NHS. And that's not just happening in the PACs, MCPs and the new care model sites funded by NHS England. That's happening everywhere, being called different things all over the country. So Don this week has been visiting lots of different parts of the country trying to redesign services, and Mike of course knows what's going on in the NHS like the back of his hand. So we're looking forward to a good discussion. How it's going to work is we've got about an hour, which is going to start with a few reflections from Don and some questions from us, some reflections from Mike. But the rest of the session is mainly going to be answering questions from the audience. So hopefully on your screen you can see at the bottom a little text box where you can submit questions or comments. I'll see them on a little screen I've got here and I'll feed them to these two. And so I want most of the discussion to be questions. So like voting, put your question in often and early, and then we'll start answering them as soon as they come through. Right, that's enough from me. Don, how about we kick things off with just some reflections from you on your week, but also you've been coming here for years, working with the NHS. So how are things going so far? What are the good things you're seeing and what can we learn?
Well, thanks. I have to express my thanks to NHS England and to the King's Fund for the chance to do this. Yes, I come regularly, usually a week at a time, travel around the country. My focus in the past couple of years has been mainly on the vanguards and new care model sites, although not exclusively so. So this has been a week of immersion. Again, I think I counted 8 organizations that I visited. It's thrilling. I don't know the word for that. I full well understand the sense of pressure and even sometimes sadness or a sense of a lost way in the workforce here. People are feeling really, really stressed, and I don't want to fail to acknowledge that. But when I get to visit these organizations that are trying to invent the new models, the new way to give care, they're smiling, they're excited, and they're doing really great stuff. Each of them is an inventor locally. So I visited the Vanguard in Derby, Airwash, revolutionizing, I think it would not be too strong a word, the flows of patients in primary care, access to non-physician professionals, reaching into the community on projects on resilience. They will change the pattern of care and well-being in that community over time, and they've begun doing that now. A brilliant group, MRAT, which is a group of hospitals in which they've pooled their radiology services more or less in the Midlands. Extraordinary changes. They really are starting to think together as one system, even though they were previously highly competitive hospitals. I don't think they thought in such a cooperative way. That foundation of cooperation is going to allow them not only to perfect radiology services and I think reduce costs, but there's no reason quickly over time, this can't spread to other hospital-based services like pathology, and you'll see cost change and quality improve. Lots of teamwork, reaching across boundaries among general practices. The Principia group, also in the Midlands, extraordinary. The GPs and their leaders have come together with a whole new way to think about the way to work together in care of patients. This is real. It's learning, which I have felt for years is the great advantage for the NHS, its ability to learn. And they're overcoming some of the feelings of being pressed on. Instead of they're saying, look, it's our community, we care about each other, and we're going to make a difference.
But so, Don, you talked about things happening in different places and the ability to learn, but often we get accused in the NHS of being very good at having pockets of great stuff going on and not actually being able to spread the good practice. Have you seen that? Is it in pockets, or are things spreading? Are people talking to each other? Are they learning?
It's still mainly pockets, and that's how you started. So you actually very courageously, I think, the country invested in these models, these new models. And I want to be clear, although the vanguards are exciting, I think there are 50 of them or so. I probably have seen 40. They're not the only innovation that's going on. There's a lot of innovation going on, but your country has invested in this kind of, why don't you go try it? We trust you. We think you can figure this out, and given resources and permission to some localities, and they're doing it. No, it's not spreading in a systematic way yet, but it sure can. Look, if you don't have the innovation to spread, you can't spread. So that's the beginning. I think what I've been saying, the kind of way I've been framing it now is, this is phase one of the 5-year forward view. Phase one has been an investment in innovations that more are likely to realize the better care, better health, and lower cost imagined in the 5-year forward view. It's really well underway, not finished. There's lots more work needs to be done. But now you start to have these gems around the country, not just vanguards, but including the vanguards, which if we do it right next, this can be brought to a much larger scale. I'll say one other thing, not in the way you plug in an appliance. This isn't like taking the toaster from Airwash and plugging it in a different city. It isn't going to work, but adaptation can. And if we use these pioneers as teachers, we can learn lessons, and they can be brought anywhere and adapted locally. That's the next stage.
So I want to come back to that point about adaptation, but first, so Mike, hospitals and their role in these new care models. Don's painted a very positive picture. Do you see the same positive picture? We know that hospitals are under big pressure on finances, on quality, and they've got a job to do just to manage within the existing model of care, but they're also being asked to transform. Tell us a bit about how you see it.
First of all, I should say that although my title is hospitals, only after I was appointed did I discover that hospitals included mental health trusts, ambulance services and community health services. It doesn't include primary care services, that Steve Field does that. It doesn't include care homes, which Andrew Sutcliffe does. But we work very closely together. And we are seeing change happening. We are seeing change within those organisations, and that was much needed. So we are seeing care homes that were inadequate go to being good. We're seeing the same in general practice, and I'm very pleased to say we're seeing that in hospitals. That was needed, and I think it's important to recognise that we will still need these big building blocks. They're not going to disappear, but what also matters is that the different parts work together, and the integration agenda, the new care models agenda, it's not just optional, it's vital. And we published a report not that long ago at the end of our first round of inspection of acute hospitals, where we said there was a burning platform. The rise in numbers of people going to A&E, the flow through hospitals, the problems of discharge from hospitals, unless we change the model of acute care, it's not going to be sustainable. So we've got to do something. The exciting thing is that we're beginning to see people respond to this, and respond across systems. Some new care models are genuinely very new. Digital health is an example of that. Others are actually putting the pieces together in a different way, which is much needed. But that's actually also about the different parts working together. So general practice is working much more closely with hospitals, which hasn't really happened much in the past, but we're now seeing it happening, and it doesn't matter whether you're in Northumbria or whether you're in Yeovil, those things are happening, and they're elsewhere as well. We're seeing mental health trusts that are actually managing care homes. So these things are happening, and they're not necessarily within the vanguards, but they're happening. But I think what's exciting about vanguards and new care models is the potential for learning from each other. It doesn't have to be exactly the same. The toaster example, I think, is a very good one, which I shall remember. But I do think that it's that question of learning, and which we haven't always been very good at doing in the NHS. We've done it in pockets. We did it, I think, in cancer a few years ago. We did it in heart disease a few years ago on a condition-specific basis. But I think now we've got to do it across health systems and with this integration agenda and new care models. But we can. and we're seeing it beginning to happen.
But I suppose what you're also seeing is big pressure in big provider organisations. And there's always a tension, isn't there, between delivering on targets and managing care today, but also redesigning care for the future. Do you see that tension playing out? And where do you prioritise?
The thing is, we won't solve the tension of hitting targets unless we do these things. And that's why I think it's going to work, because actually there is a good driver saying, let's do things differently. Just doing more of the same, I don't think is going to solve the problem. And I think it's not just me saying that. There are lots and lots of people around the country saying that.
That's right. So you've both talked about learning, adaptation, spread. What role is there for the regulators changing the way they work with local organisations to make sure things spread within systems and across the country?
Well, first of all, we mustn't be a barrier. And we're absolutely committed to not being a barrier to innovation. The one caveat I would say to that is people need to let us know what they're doing so that we can register new services or whatever it may be in proper fashion, because actually there is statute, there is law, services have to be registered. So if you're opening a new service, it's got to be registered. So let us know what you're planning, and that's why we are watching vanguards, we're watching different health systems emerge, and so we can adapt to that. I'm absolutely convinced we can adapt to that. I think we can, first of all, if a mental health trust is managing some care homes, then we need to know about that. We need to plan for how we're going to inspect that. We also need to work out how we're going to do the ratings of the individual components, but also what that means in terms of aggregating it to the whole system. We can do that. There's no problem there. I think what's also interesting is how we assess pathways of care. That's more difficult, but again, I think whether it's a frail elderly pathway or whether it's a stroke pathway or whatever it may be, we can do that, and that actually will be an exciting thing probably for my successor to do rather than me.
Because there is a challenge, isn't there, if you're held to account for your own performance as an organisation. It can sometimes be a barrier to working across the system.
It can, but I think one of the things there is what are the governance arrangements between organisations. So if you're looking at the urgent care system, what about the delivery board for that, and what are the arrangements, and have they actually set those down, and then are they adhering to it? Are they all playing the part that they have said they will play?
And I suppose part of the job is accountability for quality of care at system level, but there's also measuring success to understand how you're doing as you go when you're designing, implementing new models of care. We've got a couple of questions already coming in about how do you know whether you're doing stuff right. Don, I want to ask you that question. So if I'm in general practice or I'm a district nurse and I'm working to put in place a new way of doing something for my patients, how do I go about understanding whether it's working?
I would say at some risk, the same way you learn anything else in your life is working. Being there, observing, in dialogue with each other, and most importantly with your patients and their families, will tell you a lot about what's going on. Trust local sensing, the local sense-making process. For the researcher, the academic, that's an unsatisfying answer, because they want to aggregate across many different replicas of something to say, does it work or does it not? But the actual learning process is highly local. We can help, we, NHS England, if I may flatter myself, help by instrumenting. There are ways to help local units adopt forms of measurement that would work locally, although they may not be academic measures. They're locally useful. And I see that. I see organizations finding, we found a way to study physician morale or waiting times. The other thing is to focus on what the patients are telling you. Patients, families, carers. They really will tell you what's going on if you listen. And some of the most exciting new care model sites are doing that. They're doing it in ways that are just breathtaking. To say to the essentially you're saying to the patients and families, you're the boss. Tell us. You give us our scorecard, and they find different ways to listen and then respond to the listening. Aggregating as a nation, for example, there are a number of vanguards that are working on new ways for GPs to relate to specialists. George Dingle's work in Morecambe Bay, work going on at Bart's and Tower Hamlets that I've seen, and 3 or 4 others. They're saying we can change the flow here so that much more of the specialty work can stay in the general practice where the general practice wants it and the patients want it. Specialists devoting their time to to what they need to. I think getting those models together and then learning from them could generate some real testable ideas about new forms of specialty care.
So a related question still about measurement. We've got someone called Sean who's saying he's done loads of process improvement projects and he's used to looking at the data like you've described, set a goal, measure progress towards it. And his point he's making is progress is often very incremental and slow.
Yes.
And often you only know over a longer period of time whether something's worked. Are these places being given the time to test, fail, redesign, slow process of change?
Yes, I think there's been a sense of generosity in the vanguard system, saying we know it'll take some time. I'm a pediatrician. A child doesn't learn to ride a bike without falling off the bike. It takes a while. Relationships have to be built. That's a very tough matter, which is when you take the new primary care system at Arawash or Principia or Mid-Knots, they've taken a year and a half to build conversations among the groups. And if anyone were to come in and say, order, do it now, they're misunderstanding this. This is about relationship building. So I'd say pretty good so far, especially in the new care models. For the future, for the leaders, they need to understand this. These are organic processes. They're not physics. And they have their own tempo. A while to get to know each other and build relationships. I hope and I think the NHS will be smart enough to give them the time.
Like at a national level?
Well, certainly having observed the NHS at national level over about the last 17 years, there is a tendency to expect results very quickly. Yeah. And that's irrespective of which party's in government. We want things and we want them done now. I completely understand the driver behind that, but Don is absolutely right. Forging those relationships does take time. Building movements for change, either local movements or national movements, takes time, but can then be very, very effective. But I'd also echo what Don was saying about listen to the patient as the evidence. Just yesterday I was at an event organised by a new organisation called Helpforce, which was about volunteering. 7 acute trusts in the country, all sharing their experience of what they've really done to bring volunteers into the hospital and to use them much more imaginatively than I remember in the past, where in the past the volunteer pushed the trolley around so that you could buy a toothpaste or whatever, but not much more. And now they are getting involved in all sorts of different ways. Possibly one of the most encouraging was actually facilitating discharge from hospitals, which we know has been a problem. Now, how did they know these things are working? Well, first of all, the patients were saying so, and secondly, once they were established, the clinicians were saying, please don't take this away. And that both of those, to me, are pretty good signs that there is something worth having here.
Can I to embarrass Mike a little, in a prior life, when we first met each other and began working together, we were a bit younger. Mike was overseeing, he was in charge of the network of cancer networks that the country had set up to try to solve some of the gaps in oncology care. That we're talking about the year 2000, 2003, so on, I guess it was the interval. And what happened was the nation established a learning network under Mike's supervision, but with many of his colleagues. It was brilliant. It made, the results, I think, were terrific. And the ethos, the learning, I was amazed by. I don't know if I'm overstating that, but you did a great job.
I'm sure you're overstating it. But,
how good a job did you do?
But on the other hand, I'll take it.
So, Donna, your point about adaptation that you made earlier. So Mike's already said he liked your toaster example. We've had 2 other people say they like your toaster example. But relatedly, so we obviously know there's something that might work in a local context. You can't just drag and drop it to a different local context. No. But there must have been some ingredients in the first example that worked. How do you identify what works and what is relatively generalizable? And how do you recognize the importance of local context and the need for things to emerge locally?
Yeah, I think of it as there are general principles and specific applications, and both apply. And part of the learning process is to extract what we're learning generally. What would be an example? A lot of the progress in primary care flows that I'm seeing have to do with upskilling non-physician clinicians, giving them much more latitude to work, like the embedded pharmacist I saw in Arawash, who now does things you just don't see a pharmacist do, but she's making an enormous difference there. You can see it right on site. So the principle is, think about all the abundant talent you have in professionals other than physicians here. Are you using them to their greatest advantage, and what could you try? Now, what you try locally will be adapted to the local context. You may not have a pharmacist like that to try with. You might have a physio that could do the same thing. So extract the principles. This idea, for example, my earlier comment about, say, Bart's and Morecambe Bay, having a different way for primary care and specialists to work together. So the specialist is trying not to see the patient, not keeping the patient away, but saying, hey, could I help you learn stuff that you'd love to know? And the patient then can get care at one stop with you. Everybody likes that. That's a principle. How it works in your patch will be your way to adapt. The learning process is principles and local adaptation. One more thing. The local adaptation requires skills, and there's another threshold here, which is NHS England willing to invest in building the improvement skills of its entire workforce? Because they're not in your DNA. You have to learn them. And I hope it's yes.
Well, Don, is it a combination of improvement skills and time? So it's not just having the skills, but the slack within your day job to improve your job?
You could make a list. A little slack is necessary. You just can't, you have to have a moment of reflection. There's some diastole in your life that allows you to just get ready to try something. Yeah. You have to have skills. You have to know, how do you try something locally? What does that mean? How do you measure? There's some metrics to do. And you have to have permission to fail. That's a really important point, which is the first time you try it probably won't work, but a dynamic learning organization or a learning nation has everybody saying, I tried it and it didn't work, but here's what I learned, and that's the resource, and that's a cultural matter, and it's got to be nurtured by the leaders.
And I mean, we still see far too few hospitals which have a recognised improvement methodology embedded in them. Interestingly, the ones that do tend to be the ones that we've said are outstanding. And we haven't said they're outstanding just because of that, but it happens to be a characteristic of, it doesn't matter whether you're talking about East London Foundation Trust or Salford Royal or Western Sussex, they all have that embedded within them. And they've gone on a journey. First of all, you've got to get the cultural alignment of managers and clinicians. You've got to get people pointing in the right direction. But I think ultimately you do need that improvement methodology, and you do need it embedded. But that's often a step after you've done a bit of turnaround.
But to Don, you are the QI guru. So if we're thinking about methods, am I right in saying that you've got Lean, Six Sigma, you've got a range of different methods that people say work, but actually the most important thing is have a method and do it systematically?
Yeah, I mean, they're kind of like sects within the overall school. Yeah, I mean, the basics of improvement everyone's familiar with because they use it all the time in their lay lives. You need to have an aim. You need to want to do something, and it could be improve mental health or reduce weights. You have to have an aim. You have to have a way to know if you're getting better, which is a good enough measurement. Doesn't have to be perfect, but a way to know how it's going. And then you have to have a source of ideas for change. If I'm going to be better I don't play cricket, but I suppose if I was going to try to get better at cricket, I need some ideas about how to hold the bat, the stick, whatever it's called, or how to run properly. So and someone else knows you're a better player than me. You tell me. Right. And then you have to learn to test. That we call that Plan, Do, Study, Act. That's just an acronym, but it means you got to be able to try it because you're going to learn your way to success. Those are the basics. And any model you pick, whether it's Lean, Six Sigma, the Virginia Mason model, whatever, tell me the name, it'll have those embedded in it.
And so the last question on spread, because we're getting loads through about it, is, so say the three of us have come up with a great model, I'm a general practitioner, you're a specialist, and we can communicate better because we've done something whizzy. Do we write it up and do we take it to our neighbours and say, this is what we've done, and it works perfectly, and adopt it exactly as is? Or do we say, this is what we've done, take the bits that work, fix some other bits, ditch it, make it work for you? How does it actually work in practice if I want to spread a good idea?
Writing up is only part of it. I mean, yes, by all means write it up, but actually sharing it in events and meetings and describing it to each other, getting people enthused. This is the building of movements. I was mentioning the one about a movement on volunteering, but it could be a movement on how to improve maternity services. It could be a movement on a whole lot of different things. And actually, I think a bit of human-to-human contact is really... And we do far too little go visit in the NHS. Don has probably visited a whole lot more of the NHS than most people have. Yeah. I've seen a great deal of the NHS as well, although not all of it. But actually that business of go visit, there are hospitals that are 25 miles apart from each other, one could be outstanding and one could be inadequate. But how much has one hospital visited the other? So I really do think go visit matters, and bring them together in neutral territory if need be.
I want to thoroughly endorse that. I think it sounds so simple or so hokey, but no, go look. If you talk to the successful champions, and there are many of them in the new care models. I'm thinking of Tim Taylor at MRAT, for example. So he helped architect this relationship among 7 sites. I say, Tim, how did you get them involved? He said, shoe leather. I drove my car. I went there and I talked. Not once, 5 times. You talked to Duncan Gooch at Erewhon, bringing on now I think 12 general practices. He describes buying them beers. I mean, it's a getting together and talk, and it won't replicate. It's much more relational than that, but I don't know another way to do that. Sometimes you can do something structurally, which the NHS will do, campaigns. Everybody why don't we all work on central line infections? You could have an ambassadorial function. You could say to some of these champions, this year, here's some train tickets. Could you please visit these 10 spots and help them out?
So it's more relational than technical.
I'm afraid so.
And let's remember that some of these national campaigns really do work.
Yeah.
So if you look at the results of the inpatient survey that the CQC does each year on what patients say about the cleanliness of a hospital, it took a big step up in the mid-noughties in response to a campaign. And you can absolutely see that patients were able to see the difference. And so there are some things that can be done nationally, but I think a lot of it has to be local, and it is about relationships.
And you do have a success track record here. If you look back at John Oldham's work on weights, or Mike's on cancer care, or the work on C. diff, you've actually done quite a bit of pretty broad scale.
But you're talking about national campaigns. Part of it actually about, so we've now got STPs, which cover some quite small populations, 300,000 up to nearly 2 million. Is part of their job to say, look, across the geographical area that we're operating in, where does good practice exist, and how do we spread it? Is that what STP leaders should be thinking about?
Well, I think STP leadership is about saying we all need to work together. We are not separate islands, or if we are separate islands, we're not going to get the best for our patient population. So how are we going to work together? And I think to a large extent in recent years, we've done much too little of that, of bringing people together and saying, actually, the system has got to work together. That, to me, is what STPs have got to do.
The native affections matter. So the STP boundaries may not correspond to the truly affiliative affective boundaries. What am I part of? What community am I in? Who is us? Because it's the us that's going to actually get this done. And I think as the STP process plays out and maybe moves into the accountable care systems, that's really important for the leadership to keep in mind. Find the us and help them do their work, even if they don't happen to match the boundary of the accountability unit you've just drawn.
So I'm going to have to ask, because we've had plenty of questions about it. We often avoid any conversations about structures, organisations, and it's the services that matter, which is quite right. But people are saying we've got STPs, we want to integrate services. Does that mean that we're going to have to change how organisations work together, have new contracts, have new organisational forms? Mike, what do you think?
I'm quite sure things are going to have to evolve. I think that the interesting thing is how much you can do before you do that. I think if you just look back over the last few years, how change has been brought about without requiring new legislation in how organisations work together. NHS improvement doesn't actually exist. The TDA and Monitor still do, but everybody knows that NHS improvement does exist. By the way, I was having that conversation with Jim Mackey yesterday. So
telling me leads an organisation doesn't exist.
So we can do an awful lot without having to have new legislation. Ultimately, yes, we will. But and I think if we can do that at national level, we can do it at STP level as well.
Mike, I mean, not so much new legislation, but locally with organisations working together. If we're saying collaborate across boundaries, I suppose. Well, actually, can we just get that done anyway? We don't need to worry about merging organisations. Surely this is about which services need to work together better, and how do we remove the barriers?
I think we will need a mix economy on that one.
Right.
I think sometimes it will make absolute sense to merge organisations. We're already seeing sometimes actually it's just having the same leadership team in one organisation and in another, and not rushing to merge. If you look at University Hospital Birmingham with Heart of England, if you look at Salford Royal and Pennine Acute, that they've gone down that model of having a single chief executive and chair, and now it's happening in Brighton along with Western Sussex. They haven't actually had to merge, but that is a model, hopefully, to see major improvement in quality of care, and it will bring those organisations together. At some point, they may decide to merge.
So another more technical change that's happening is new contracting forms. So we're seeing contracting models emerge, which are capitated budgets, new financial incentives. People often talk about there being barriers about incentives in the system, and people often looking to the States and thinking ACOs are aligning incentives. Don, can you talk a bit about the role of new contracting models, new financial incentives in improving care? And are we thinking about the balance of those sort of financial motivators versus the intrinsic motivation to improve care? We were talking a bit about this yesterday.
Well, I endorse Mike's comment on non-contractual relationships. In fact, if you had come with me and visited these vanguards, you'd see alliances forming, what Amanda Sullivan's doing in the Nottinghamshire area. Or is that mid?
Don't worry.
Yeah, she wants to knit together a lot of collaborative activity. She's doing it with an alliance, just people trying to get in the same room, work together. Duncan Gooch and his CCG chair in Derby. No, I don't think there's very much formal contracting going on. It's just let's get together and do this right. That can be done. On the other hand, you see what David Slocum's doing at Royal Free, and these are much more structural. We'll see. Some of them will work one way or another. I guess overall, look, it's my opinion only, and it's worth that only. I think relationships beat contracts if you can do it, and I think intrinsic motivation beats extrinsic motivation. And if my feeling in my country and yours is let's lighten up a little bit here. Let's not assume that we can set up the payment mechanism exactly right. So finally, Hugh Alderwick will do the right thing. Yeah. Hugh Alderwick wants to do the right thing, and if he's not, I might have set up some circumstances that make it hard for him to do the right thing. Yeah. So that makes me very interested, for example, in pooled budgets, population-based reservoirs of resource in the hands of responsible leaders like I meet who feel dutiful about meeting the needs of their population. They have a lot of flexibility. They can hire more community health workers instead of a cardiologist, or they can move money around. So that's not incentives. That's structuring the flow of money so we have the latitude to do what matters. And I'm a big fan of that.
So I want to talk about something completely different. We've had a whole set of questions about the social determinants of health, really taking seriously prevention, not just about healthcare prevention, but about the broader aspects of people's lives that really matter to them, like housing, like employment. So is there any good practice either of you have seen in terms of the vanguard sites, other areas that are really getting serious about going beyond healthcare to address those non-medical needs?
I have seen that, and some of the vanguards are really moving into that space. I keep mentioning Derby and Erewash. About half of their effort is community-based stuff. We met Jessie at the Erewash Center we were at. Jessie is 90 years old. Her children have moved out of the community. She was a lonely and I think somewhat depressed woman. She says so. Now involved in a program called Time Swap, I think it is, where this is the health system supporting people to trade resources. Jessie knits, and she says, before Time Swap, I could knit, but I had no one to knit for. Now I do. Well, imagine what's going to happen to her sense of well-being. We had a story last night from, I can't remember the center that did, and I don't think it was a Vanguard, where the CEO was talking about the arrangements to get elders into housing, good, solid housing with a community level. And he was talking to a man, and he said, what difference has this made? And he said, well, last year I got 3 birthday cards. This year I got 54. You're changing people's lives by reaching out. I'd say it's a frontier. That there's more talk than authentic progress here, and I really, really hope that England takes advantage of its single-payer environment to get really serious about social determinants now and use these structures to do those kinds of things.
And so, of course, we also have more narrowly defined adult social care, which has a clear interface with the hospital system, with general practice. How do you see the involvement of local government and adult social care in particular in the vanguard sites in these areas that are innovating?
Well, I probably don't see that as much as other people see it, but I see the need for it.
Yeah, right.
And the need for social care and healthcare to work together. If just to give an example of like where healthcare and social care could and should be working together and are in some places, it is what about the healthcare going into a care home? Yeah. That's the GP, it's the pharmacist, it's specialist nurses, whatever it may be. And I think if you go to places like Northumbria, you'll find that they have done a great deal on that. I'm aware that in the Netherlands, I think about a third of the population die in a care home, whereas it's nearer to 20% in this country. But one of the things about the Netherlands is that their care homes have more medical care input, and I think we need to really look at that. And that's an integration question. You know, it's about saying, actually, it is good for the human being, the person, to be staying in that care home and not having to bounce in and out of hospital the whole time. It's good for the healthcare system if that happens. So I think that's an area where there is absolute need for health and social care to work together.
The big surprise to me in the Vanguard system was that the care home Vanguards, there's a cluster of them, are among the most successful of all. And they're doing what Mike said. They're really thinking holistically. You go to Sutton and watch what's happened in the Sutton care home in relationship to hospital. Many fewer people traveling. When they travel, the care is more effective. It's terrific. And for some reason, that sector seems able, willing, and ready to think in these holistic terms.
So everything we're talking about relies on staff changing the way they work and being engaged and feeling like they want to improve service and have the time to do it. We've got a lot of questions about culture change. It's a broad term which can seem quite abstract. What on earth does it mean in practice, and how do you go about, as a leader in a system, as an STP leader leading a trust, to try and change culture to be more focused on improvement, innovation?
Well, just starting from what we know, and what we know from things like the NHS staff survey. First thing is, we are very lucky to have an NHS staff survey that tells us, that asks the same questions in all the 238 trusts across the country, whether it's ambulance or community or mental health or acute hospitals. And there are some key questions in that. One of the questions is, I can't remember the exact wording, but does your organisation give top priority to quality of patient care? Now, if they're not, that really worries me. And that's one that you can track through and see it change. Is this a good place to work? Would you recommend this hospital as a place for your relatives to be treated? Those are questions you can track through over time, and you can see huge differences between one hospital and another. Now, we've recently published a report on 8 hospitals that have improved very considerably. So CQC has been back and has rated them either from inadequate up to good or from requires improvement up to outstanding. And in each of those hospitals, what we have seen is major culture change as measured by the staff survey. They have improved much quicker than the country as a whole. And so how have they gone about it? They've gone about it in different ways. But essentially, first of all, they've given this priority. And the leadership team have seen it as a priority. The leadership teams have become much more visible. They've gone out and engaged with their staff. They've looked for some quick wins. They've asked the staff what they think needs to be done, and they've actually listened and then acted on it. But they've gone about it in different ways, and I'm not saying there is one way. What I am saying is, if you look at the change in culture if you take a very, very large trust like Leeds, which has gone up from middle of the road, requires improvement, to good, which is a huge change for a trust like that. It's also reflected in how they've improved on their staff survey. But they've really taken it seriously. They've set up ways of staff giving ideas for how things could be improved. I think I read that they'd had 45,000 ideas come in. You know, yes, they've got 15,000 staff, but that's a huge number of things come in, and they have changed the culture in that hospital. They're not the only ones, so it can be done. And I think again, go out and look at what other people have done. Go and talk to Julian Hartley. Go and talk to Jackie Daniel at Morecambe Bay. Go and talk to others about what they've done to turn the culture around.
I think it is leadership dependent, and more than I wish it were, because that's hard. But it's what Mike's saying. Learning our way to the new NHS is going to involve leaders who are willing to say, "I don't know the answers. I'm here to help you do what you know to do. I'll get you the resources and support you need. How can I help?" And not, "I have an answer. I'm holding your feet to the fire, and we now are accountable for you. I'm making you accountable for your behavior." I believe in release, not control. The other thing is more businesslike. I had an interesting encounter on this visit, talking with a chief executive in whose patch there was some very good work going on reducing hospital use. But he was CEO of a hospital. And I said, "Is this good or bad?" He said, "Good. Hard, but good." I said, because my test of integrated care is that hospitals seek to be empty. And he said he was. At which point, a colleague spoke to me during a break saying, "My CEO would never say that." That's going to matter, because the workforce will know. If you want me to actually find a new way for patients not to need that bed or that specialty consultation and do better, I'll do it. But if behind the scenes you're saying, next patient, I can't do it. So there's some tough decisions for leaders to make here.
But if I work in a trust or a group of practices where the leadership isn't vocally supportive of these new models of care, but I'm ambitious to change the way services are delivered for my patients and I want to improve things, what do I do then? We're not all chief executives.
Do it anyway. I mean, if you've got the gumption. What I say I get asked that question a lot, and my answer is unsatisfying, I'm afraid, but it's you only live once, and you can live that in a reactive mode, looking up to say what I'm going to be rewarded for. You can say, I'm here for a purpose. I came into healing to be a healer. I have ideas. I like my colleagues. We're going to do this together, and you navigate your way to change. And we see that. We see leaders emerge here who do what they can and have fun doing it. And ideally, the leadership comes around, or there'll be a convergence here. But passivity is not a happy place.
We see this in having individual services that we are rating as outstanding in the context of trusts that are clearly requires improvement at best. And that has to be local leadership that's done that. You don't have an outstanding critical care unit in a hospital that otherwise requires improvement without that having been the case. And I could take you to a number of different places where that has been the case. And fantastic that they've done it. And we see children's services that are outstanding in hospitals that are not doing well. We see it in maternity. We see it in critical care. It's more difficult for the A&E medicine surgery where the acute patient flow all merges together, but you can still see then outstanding individual services within that. So, I think we need to be able to recognise that and reward it at least through recognition, and then say, okay, well, if that person can turn around that part of medicine, why don't they start trying to turn around the whole of medicine? And then maybe they're the next medical director of the trust or whatever, and bring people on, because we desperately need to bring people on.
So do we need to be a bit better than identifying the talent within the clinical workforce where it exists? Because we often talk about clinical engagement and how difficult it is. So is there a job for leaders to say, look, where within this organisation, within this system, does the energy lie, and how do we...
And again, if you go to the very best trusts, they don't have any difficulty in getting people to step forward to be clinical directors. It's something that's given status. People actively want those roles. But in some other places they don't. So we've got to encourage that and facilitate it.
It's not like there's just a few of these people. There are many, but the bias at the leadership level is to say yes, not no. It's to say, great, try it. And that can be partly finding the special hero and making sure they have the space to do something new, or it can just be, the signal you're giving to the workforce, which is yes.
So we've got a question from someone called Nick Clegg, who can't be the ex-Lib Dem leader, I assume, but it may well be. And it's a great question. So we've been talking a lot about innovation and stuff going on locally, but Nick is asking, how do we protect against a huge proliferation of different solutions in different places, some of which work, some of which don't, and miss the opportunity for doing things once or twice at a national level when they really work and helping that happen? So Do you see this risk, Mike, of too much innovation and not capturing what works? And
risk of too much innovation? No, I don't. Risk of us not learning lessons from innovation? Yes, I do, and that's why I think it is very important that that NHS England is actually observing what's happening and trying to capture it. That when we, as CQC, are going around the hospitals of the country, when we see very good things, we report on it, and that actually the various arm's length bodies need to talk to each other and make sure that we jointly capture it so that we know what's going on. I don't see a risk of too much innovation. I have to say that's not a worry to me.
I suppose it wouldn't be too much innovation, it's too much difference, and when things work, not capturing it. So I suppose you've answered the question.
I think it's capturing what works, and then actually... just because I remember yesterday, it was going back to my volunteering example. One hospital saying they'd actually devised a way of bringing volunteers on from the day that the volunteer puts themselves forward to being able to start work down to 3 weeks. And another hospital says, oh gosh, it's still taking us 3 months. Let's learn. So, whoever's got it down to 3 weeks, fantastic. We can learn from that. So I think as long as there's that spirit of wanting to learn from each other and sharing with each other, we'll get the best of all worlds.
Do you see a related risk, Mike, of... So say I'm in an area where there's a fantastic vanguard that's improving care for me, my friends, my family, but a few miles down the road they don't quite have that vanguard in place yet. Care isn't transforming as fast. That we see big differences across the country in quality of care.
I think we will, and we will reflect that where we see it. We will see changes in flows to a certain extent. When the very first hospital that we rated as outstanding was Frimley Park, and in discussion with Andrew Morris there, what happened as a result of that was that those who were living on the periphery of their catchment area started coming towards Frimley Park. The local population was always going to be Frimley Park and wasn't going to move, but they did see a change, and I think we see it more probably in maternity services than others, where people have got more choice, if you like, of where to go. But I think then others will catch up. Yeah. And over time there will always be somebody who's a bit ahead and somebody who's needing to catch up, but that's no bad thing as long as the catching up is being done. And
it's being supported to be done by national bodies.
Yeah.
Don, from the US, there's sort of where variation is extreme and the norm. Do you have that worry when you look at the new care models emerging?
No. Pluralism is your strength, not your weakness. Someone once said to me that the biggest problem with the NHS is its size, and the biggest advantage of the NHS is its size, because so much can happen. Yeah. And yes, you have to have the sensing mechanisms and the learning processes, and never expect that in the end you're going to say, aha, we found it, this is the model. That is not how human development works. And so it's a soft answer, but it's the more innovation, the better. In some ways, the variation is instructive, and then you have to manage learning processes that help people exchange knowledge with each other. It's the way any great football team gets better.
And so within the different new care model sites, different examples of integrated care in England and other countries, you see some staff working together in different ways, so more coordination between GPs and specialists. But you also see some staff doing new things and different things that they weren't doing before. And you see some new roles emerging, like care navigators, social prescribing schemes. So how do we change the workforce to adapt to the new models of care we're developing? Have you seen any examples of that in the vanguards you visited, Don?
The workforce is readier to adapt than we might give them credit for, if their input is used. It wasn't a vanguard, but I visited the Guy's Hospital Cancer Center yesterday. Was walked around by Mairead, the chief nurse, and you can feel the vibrancy of the community. You get the sense that everybody wants to help. They want to find the defect. They want to close the gaps, and they're doing it all the time. The whole workforce is mobilized as inventors with patients and families, and it's a different dynamic. What I keep noticing, it's the dynamic of a healthy life. If we could demystify all of this, it's just what you do when you're doing something you love. So if you play chess, or you knit, or you're on a basketball team, or you garden, you're doing this. You're getting people together, you're trying new things, you're dissatisfied with your current state, and you want to move to the future. That's the workforce we want, and it can be made, it can be created.
So I want to ask a question about measurement and outcomes. So we've got a range of questions coming in about different types of incentives that people are faced with. sequins, payment incentives, QIP targets, so cost improvement programs. We have CQC. We have a scorecard for CCGs. We may have a scorecard for STPs, different ways of measuring. So this is part of the question about how in your local system do you know the outcomes that you want to deliver, and how can you make sure you're all on the same page to delivering them? Mike, I'm looking at you. So how might this evolve so there's less fragmentation in the way we're measuring things and perhaps more coherence about what the system level outcomes are?
Well, I think we've got quite a lot of system-level outcomes, and we need to pay heed to them. There are certain things that we can only measure by having good national clinical audits, for example. I cannot walk onto an orthopaedic ward and know whether its outcomes for hip replacement are better than somewhere else. I need to be able to look at the National Joint Registry or whatever and actually see what the outcomes have been for the last 1,000 people that they've treated. Equally, if you look at fractured neck of femur, if we know that there is a relationship between getting to theatre in a reasonable time, having an orthogeriatric assessment and getting the rehab started, all of that, let's look at those factors because that will tell me this is a service that I would want my family to be looked after in or not. So I think we need to work on what those national metrics are, and we've got a lot more of them than we had 10 years ago, that's for sure. And we need to, although the timeliness measures, the access targets are very important, they're not the whole of the story. That they are one aspect. The 4-hour target does tell us an awful lot about flow through a hospital. It's much more important about flow through a hospital than it is actually about what's going on in the A&E department sometimes. But yes, we should measure that, but we also need to measure outcomes that really matter to patients, like will my hip still be functioning in 5 years' time? Mm-hmm.
And so we're talking about outcomes-based contracts in different parts of the country and new ways of paying people based on outcomes. It must be quite a difficult job if you're a CCG to understand which are the ones we're going to choose and which are the ones we're going to incentivise. Do you have any advice when you're thinking across an STP area or in a new care model vanguard? How on earth do we define what the outcomes are that are important to us?
Well, there are certain outcomes that I think we can look at and be pretty clear about, and there is no single outcome measure, in my view, that is utterly reliable. And that's partly why we need a suite of outcome measures. So the things like the SHIMI or the HSMR are signals. I would not want to base a whole system on one or other of those. But if you have high mortality, you should pretty well be looking into why. And the first thing you should be looking at is how well does this trust really manage the deteriorating patient? Do they spot the patient is deteriorating? Do they have a proper process for escalating? Do they then respond to that? So I'm not a believer that there's ever going to be one single outcome, but what we do at CQC is we look at a whole suite of different outcomes. Now, how you change that into contracting, I'll leave those to the people who are on the commissioning side, not on the regulation side.
Very good. So we've got a few questions about new leadership models. We've talked about culture change. We've talked a lot about within organisations, how you embed a culture of improvement. There's a question about across an area. You've got leaders of different organisations who need to work together, often big characters who have power in their local system. How do you get that conversation started, and how do you work together across different organisations who might be more used to competing than collaborating? Don, we'll start with you.
Well, they must work together. We're not going to get integrated views to help populations unless these leaders get in a room. And I don't know how to make them do it. I think if there's an accountability structure, if you want accountability, let's make them accountable for that, which is let's have leaders rate each other for the degree of cooperativeness and use that as a scorecard. I'd buy that one. There's a training issue here. We haven't talked about the training of the young, but I would invest in the future by making sure that as we train our young professionals, our managers, we embed in their development, their curriculum, their supervision, their skills that are relevant to improvement, one of which, maybe the prince of which, is cooperative behavior and generosity to each other. When it isn't going on, it's a problem. I don't have a simple answer. Someone is supervisory, and they've got to really encourage this. I think on the whole, leaders are probably like people, and they, they probably would enjoy playing together a little better. And you do see that. You see these stories emerge. I mentioned the MRAD group, but there are many where there was a lot of rivalry, a lot of distance, a lot of history that people carried, grudges. But over time, with dialogue, and by the way, one other thing, with the patient in the room, the community in the room, they say, let's take a fresh start at this. That last point about the community in the room matters, because the people won't countenance this. They'll watch the rivalries and they'll say, oh, wait, hold on a minute here. It's my health, it's my cancer, it's my kids, it's my future that you're talking about. Yeah. I don't have time for you to bicker. Get together, please, and do what I need.
So, Mike, do you have
I was being asked this very question in the context of how should we assess leadership of cancer networks or cancer alliances, where a lot of different hospitals have to work together and all have different functions. Interestingly, I think we can adapt the well-led assessment that we have, that both NHS Improvement and CQC have agreed for individual organisations. I think we can adapt that to networks, to STPs. What are the key components? Have they got the right leaders, and are the leaders talking to each other? And can they document that, and can they evidence it? Partly by having people in the room actually observing whether they are. Have they agreed a strategy across the patch for whatever it is they're doing? Have they got a vision? But if they have agreed a strategy, are they actually moving to implement it? Have they got the governance arrangements between them so that they know who's responsible for what? And how are they dealing with the cultural issues across boundaries as well as within organisations? Are they engaging patients? Are they engaging the community? So all of those same things, which are what we are currently assessing for individual organisations, I think can be adapted very easily for much larger structures that cross boundaries.
And so what do you think of Don's idea of a leadership survey, where how well are you collaborating with others? It might be a nice idea.
I'm very much in favour of that. I think 360-degree assessment. Incidentally, I think we should be doing that both across boundaries. I think we ought to be doing it within individual teams as well. Yeah. We all know that there are some individual dysfunctional teams. But getting underneath that and finding out what's going on there is something that we've not done very well in the health service. So I'd love to work on that.
And also from a patient's perspective, how well do I think people are working together to meet my needs?
Yeah.
Shared aim helps. That pulls you together. And I think one of the interesting challenges, if I can be a little bit out on thin ice here, is in the next steps review that Simon Stevens has put out. He proposes work on A&E, mental health, and cancer. And you could take that one of two ways. Say, who are you to tell me what to do? Or I've got other priorities. You could say, okay, great, I'll get on board, and let's do this, and prove the possibility of progress in an area the whole country cares about. That would be a way to aggregate energies.
But there is a challenge there, isn't there? So that document clearly saying there are some things which we need to do, and there's local conversations happening now about prioritisation within a fixed pot of resources. There has to be decisions between leaders about what are our priorities.
Yeah, it's never either or. It's a 60-40 thing, but if you could aggregate energies in the communities of the nation to say, we're going to get cancer care right now, or we're going to really change this A&E pattern, we're all going to do that. We'll all learn about it. That consolidated view of the hill to take, that can help produce the cooperative behaviors. W. Edwards Deming used to say, aim creates a system. And I've always loved that. It's sort of Zen, but aim creates a system.
And actually, by working together properly, there may be reductions in cost, the quality cost relationship. If people are not having to have CT scans done at Hospital A and Hospital B, if the flow of patients between Hospital A and B is improved, would get us back on the 62-day target for cancer, for example. So there are all sorts of things that won't necessarily cost money, but will improve quality.
Fantastic. Thank you both very much for all of your answers. Thank you, everybody, for their questions, which were fantastic. There's some we couldn't answer, but I've tried to hit on the ones with the big themes that people were asking. I was going to try and ask you in the last couple of minutes, Don, about what on earth is happening in American health system reform, but there's not enough time, thankfully, for you. So, look, thanks, everybody, for joining. Hope you found it useful. Thank you, you two, for the discussion, and hopefully see you for the next one. Cheers.